As I said in the morning session, it's always a special honor and joy to come to Greece because of the strong connection that we feel on a friendly basis and on the historic connections and so forth. So it's always a pleasure, and thank you very much for this invitation. Now, as you notice, the topic is somewhat overlapping with a topic that was a symposium, but as I know, many have been, for those of you at least, that have been very much going over the emails during the previous lecture, and also for those who were looking about movies of cats dancing, etc., on Instagram and TikTok. So some of the slides will be the same ones as in the morning for those people, but the others are quite different. So we start off with a slide that I showed in the morning about the advent of sub-Q formulations for IV. However, what I didn't show in the morning is actually when we talk about moving from IV to sub-Q, you should know that actually the pharma companies have realized that there are some benefits to this concept. And if we think about it deeply, this has already been done with ustekinumab, which is approved already for several years, and we use it. But also for most of the new biologics that are now coming into the field, this same concept comes there. So both for risankizumab, mirikizumab, and some others that are in the pipeline and not still approved, this idea of induction with IV and then moving to sub-Q is actually the backbone of this idea. So it's worthwhile really going into what is the difference between IV and sub-Q in terms of pharmacokinetics leading to the TDM that is a topic of this talk. So when you administer a sub-Q of a small protein up to 10 to 20 kilodaltons, it usually diffuses directly into capillary networks and directly into the systemic circulation. So it goes very fast to the circulation with quite a significant bioavailability. In contrast, when you inject sub-Q, a larger than a 20-30 kilodalton molecule, which is what we have with IgG. So most of our antibodies are IgG1, except perhaps for mirikizumab and IgG4, but generally all our immunoglobulins are around 150 kilodaltons, and those do not diffuse to capillaries. They go through the extracellular matrix and then drain into lymph nodes, draining lymph nodes from where they eventually go into systemic circulation. So already by this figure, you realize that there might be some differences between the two in terms of rapidity of dissipation into the systemic circulation, possible effect of edema at the site of injection, and we will touch upon that a little bit, but also in terms of immunogenic presentation of antigens. So what about bioavailability? So indeed, if you look across different antibodies, the bioavailability generally of antibodies that are available both as an IV and a sub-Q formulation is generally around 50 to 70% of what would be done as an IV. Naturally, an IV bioavailability is 100%. That's a standard of measurement. So you can see for the different compounds, it's around 50 to 75% bioavailability. And I showed this in the morning. The pharmacokinetic profile of such administration differs by the fact that the Cmax of an IV, we have this peak level, and then it goes down until the C-trough, whereas this concept of maximal Cmax and C-trough are much less pronounced, if at all relevant, when you administer a sub-Q, especially at steady-state situations. And just to show you that this is indeed so I'm not sure how many of you realize that this study exists, but there was a study comparing sub-Q golimumab, Symphony, to the IV golimumab. So the company eventually decided to desert this formulation, but this is a nice, vivid illustration of the differences in PK profiles between a sub-Q formulation of the same formulation given as an IV, illustrating what I just showed you in terms of the peaks and then the troughs, which are much lower than the ones that are seen in the sub-Q on the left-hand side. And this is also translated into what we find in TDM. So for adalimumab, both ourselves and other groups have shown that if you look at the adalimumab drug levels as a sub-Q formulation across a cycle of injection, it doesn't really matter, as Ward and colleagues have shown, it doesn't really matter when you measure it in a stable situation. We also looked at patients even with immunogenicity to adalimumab, and they were included in this cohort, and still you don't see a difference between measuring the drugs at day 1 to 3, 4 to 5, or 6, and then these intervals along the 14-day cycle of adalimumab, making it much easier to measure than TDM rather than waiting for a trough level for injectable that are done at home. This was also shown recently for the infliximab sub-Q by work from France, showing the same principle works here again. So what, if I now turn my attention and our attention to the two main biologics that are like the canonical switch from an IV or a traditional IV into sub-Q. So one of them is vedolizumab, that you are all aware of the visible study. This was a double-blind, double-dummy study. It was randomized and a placebo control. So it's a 3-arm study, which was quite complex, comparing for UC patients the treatment with vedolizumab IV versus a sub-Q. So you see patients were randomized after the first 2 induction doses, so at week 6, to either receive placebo or vedolizumab or sub-Q. Now you may wonder why was placebo there at all, because we know vedolizumab is effective. So indeed, this was a discussion of the company with the regulators, deciding that vedolizumab sub-Q had to be compared to placebo rather to its comparator. So a little bit different design than what you'll see down the road with infliximab. Also tells us that this is a field that is getting more renewed every week as we speak, and even regulators are still not set on which is the right comparator for this formulation. But if we come briefly to the results of vedolizumab, so when you see on the left-hand side at week 6, and then following the PK CTRAF profile of these patients, so naturally those that were transitioned to placebo in the red line, you see plummeting downward concentration to 0 basically. But patients who receive either the IV or sub-Q have measurable levels, but the IV stays at around trough levels of a median of 10, whereas the sub-Q goes up to 20 as a median level, so almost double the concentration. Was this translated into a clinical efficacy benefit? So not much. Again, the comparison for the primary outcome that you see in the small graph to the right was against placebo, and this was proven, so the sub-Q formulation of vedolizumab was approved. And you don't see much, perhaps a very slight signal for a better efficacy, but not really an impressive one for that sake. Now, question, of course, there are many possible answers why this may be, and we'll touch on that in a moment. But I already want to draw your attention to the difference between a pre-designed formulation that is a sub-Q to what happened to ustekinumab, which was designed a little bit earlier on the way of designing pharmaceuticals, where the IV was indeed intended as an induction with a sub-Q right afterwards. So you see the difference between a sub-Q that was designed after the IV maintenance arm was already available, with the lessons that you need a sub-Q dosing that will increase the concentration rather than reduce them. This is not the case with ustekinumab, so no IV maintenance was available, and probably nowadays we would say, well, maybe ustekinumab sub-Q is underdosed, because you see the plummeting during the sub-Q dosing that is not seen with vedolizumab. Probably if one would design now a sub-Q comparator to IV ustekinumab, if such was available, probably the sub-Q level would be, the dosing would be 180 or 200, and then we would get a flatter or even rising concentration in the blood, such as we see with vedolizumab. What happens with vedolizumab in real life? So this is a nice study recently published looking at what happens in patients who are switched from vedolizumab IV to sub-Q, and you see on the left-hand side the figure showing the increase in the trough blood level. Does it translate to any benefit in terms of clinical outcomes? Not so much that one can see. So if the comparison starts actually from the second bar to the left, that's where the marks with the 2 arrows, not the first one. So day 0 of the switch is starting at the second bar, and you see overall not much different in terms of biomarkers with the switch, but also a very much comparable one. And why is that? So there, as I mentioned, there could be several explanations. I think part of it may be related to the fact that we and others have shown that actually the receptor saturation, so the alpha-4 beta-7, is completely saturated by vedolizumab already with 1 microgram per ml concentration. So let alone with 10 microgram per ml or a 20 microgram per ml concentration, all these receptors, all the target is indeed saturated, and indeed we and others did not see any correlation between the drug levels of vedolizumab and clinical response, as you can see on the small graph there. But then you may challenge me and say, well, what about the response to vedolizumab dose escalation? So we know in the IV world that indeed increase of the vedolizumab to every 4 weeks instead of 8 weeks recaptures response in about 40% of the patient. And this also happened in the vedolizumab sub-Q dose escalation that you see here, recently published by Bill Sanborn and colleagues, suggesting that when you have a loss of response to vedolizumab 108 milligrams every 2 weeks, an increase to 108 milligrams every week does recapture response in about 40% of patients and recaptures remission in about 20% of them. However, I think it's very important for us to realize that all these recapturing figures are not controlled. And this is, I think, a caveat for all our pharma companies' design of studies. There is never a control arm to show what happens to this patient if we just continue. The only such study that was available was a CHARM. And actually, when you look at CHARM in a sub-analysis, there was no difference. So patients who were failing and just continuing the 40 mg every 2 weeks, regardless, just as an open label after they terminated the study, actually had a 40% recapture of response, very similar to what we see here. So it's indeed, I think, for us, I think it's a lesson to all the clinical community that we need to think about that very carefully. Now, what about infliximab? With infliximab, we know, again, from several studies that we get a much nicer and much steeper dose response curve than we get with vedolizumab and possibly also with ustekinumab. We are aware that for infliximab and similarly for adalimumab, levels of around 10 usually are associated with high rates of mucosal healing, as shown in this study. And this was, when we look at the clinical trials with the sub-Q infliximab, I showed that in the morning and you're all familiar, so we'll very quickly go over several of these slides just to show you that the clinical study was randomizing also patients after the induction to dosing to either sub-Q or IV infliximab for the next 30 weeks and with a primary outcome at week 22. Again, this was shown in the morning, so you see the levels rising up in the green sub-Q arm, but plummeting down for the IVs, the ones who continued IV after the induction. And in real life, in the French experience, again, I was showing this in the morning, but I think it's a very interesting study showing that basically no matter what baseline dosing you had for your patient, as long as it was not 10 mg per kg every 4 weeks, so anything except quadruple dosing still gained in terms of the PK profile by elevated concentration in the blood, and 10 mg per kg every 4 weeks does not gain anything by switch to sub-Q, but then it makes us wonder whether a sub-Q is actually similar to increasing the dose of our patient to 10 mg per kg every 4 weeks. Now, Kostas Papamikael has published this really nice study, which I like, about looking at the different targets of our dosing. So the more ambitious and the more stringent your target is, the higher the doses and the concentration in the blood that are associated with achieving this target. Now, of course, these are association and not causation, and we have to be worried about hen and egg, but still it's very interesting that if we only look at clinical responses, then the levels on the left-hand side in each of these studies, both for adalimumab and infliximab, are lower than if we aim for biomarker remission, and certainly if we aim for mucosal healing, where a concentration that are associated with this will be the highest. And indeed, when you look at sub-Q infliximab, a recent nice work from Xavier Oblan looked at the differences in the drug exposure and PK/PD association of this, and you see this similar phenomena, whereby on the right-hand side graph, you'll see if the clinical remission was gained by already an exposure or a dosing or a concentration of infliximab 10 to 20 microgram per ml, informing us on possible TDM down the road. But if you look at deep remission, meaning both clinical remission and mucosal healing and biomarker remission, then you see that it's only the infliximab levels of sub-Q levels of above 20 microgram per ml that were associated with this level. Now, the inference for TDM for this sub-Q infliximab could be that we might want to increase the dosing whenever we see it something lower than 20 microgram per ml, which is not what we do with IV. So I think this is something that we need still active research, whether this is indeed which one is this the hen or the egg, and does it really mean that we have to push the hen to lay a better egg or not? In the RCT, again, I showed this earlier this morning, and you see that there was a signal for the patient who were staying on IV during the first phase to have higher CRP levels, although this was not so for the calprotectin. As far as mucosal healing, the results were comparable between the two groups, although there was a slight rise or slight steeper rise for patient mucosal healing rate if you look at week 22 in the gray for patients who were on IV, but then when they switched to sub-Q for the remainder of the study, so you look at week 54 gray bar, seems to be gaining much more than those that were just on sub-Q green bars all along the way. And this was replicated in some works from the real-life cohorts, and I'm just showing you the UK cohort, showing that after a switch, and this was a switch that was done later down the maintenance phase, so not at week 6 necessarily, and not at week 30 necessarily, but any time during maintenance, and you see this was associated with a reduction of calprotectin after the switch to sub-Q. Now, what do we know about loss of response? We know from many studies that you are familiar with that patients with PK loss of response, meaning low drug and no antibodies, or a low titer antibodies with low drug, respond better to dose intensification. This is no news to any one of us. But I beg you now the question, what we don't know. After all, I showed you about PK profile of a sub-Q, so could we possibly think about IV sub-Q vedolizumab or sub-Q infliximab substitution as useful as increasing the dose for patients with loss of response? Now, the label says on all this medication, and we usually treat it as such, saying that we switch patients when they are in remission. But if we believe our PK-PD relationship, maybe this is something that we have to actively explore down the way. What else don't we know? We know that with adalimumab, for instance, a very elegant study showing that even patients with a large cohort, population-based patients, you see 5,000 patients looking at their pharmacy dispensing notes. So patients who were delayed even 2 days consecutively on consecutive cycles already had much more loss of response necessitating steroids. So for adalimumab, this certainly is true. We don't know whether this will hold true also for sub-Q vedolizumab, also for sub-Q infliximab. I was asked this morning by Yannis Kotobaikis this question about weight, so I answered very quickly. What is an area we can elucidate it a little bit more? So what is the influence of weight on the PK of sub-Q therapeutics? It somewhat depends. So for both risankizumab and mirikizumab, you see that there is, in the clinical trials, there was an influence of higher weight or a heavier weight on the higher clearance of the drug and lower concentration. And we generally think that about most of our sub-Q. Peculiar enough, and I related to that, when you look at the rheumatology literature with sub-Q infliximab, not much of a difference in terms of clinical response with patients with, and you see the figure with weights up until almost 150 kilogram, and the regulatory note for sub-Q infliximab was not to change the medication dosing based on weight. Again, something to be remain for next investigations. Now, patients often ask me, where should I inject? And this is something that we have very little data, even though this is a very mundane situation that we all encounter. So this is something coming from the LUCENT trial with mirikizumab. There is some much less systematic data for the other sub-Q, so I chose this one to show you by way of principle. And you see in a very large cohort of patients included in the trial, when they injected in the abdomen, in the arm, or in the thigh, this did not have any effect on the concentration and the PK profile of the drug. So possibly this would be the answer that we can now give our patients. Briefly to touch upon immunogenicity, which you're all familiar, there are many factors influencing the generation of immunogenicity. Some of them are related to the product, and the pharma company, the R&D, has become very much capable of now using in silico computerized and algorithmic approaches to try to decipher the structure of a few candidates of immunoglobulin and novel immunoglobulin to choose the one that is less immunogenic and less being able to be presented by APCs to the immune system. So we're getting much less of this product-related immunogenicity that probably was a dominant one with infliximab and adalimumab as the first biologic biologics. There are some issues with the host-related factors related to the host, and you're all aware of the PANT studies showing a specific HLA is more associated with immunogenicity, and this may be true for other features that are related to the host, such as allotypes of FC receptor, for instance. And there are treatment-related, which are the most commonly ones that we refer to, such as interval and drug holidays, concomitant immunomodulators, and whether or not high or a low dose can change the immunogenicity profile. So indeed, we know for adalimumab, for instance, we usually think of sub-Q as a more immunogenic, but for adalimumab, both we and the PAN study and other studies have shown that adalimumab has less immunogenic profile potential than infliximab, even though it's a sub-Q. Now, of course, you will say, well, this is a fully humanized antibody, and the driver of immunogenicity with infliximab was its chimeric nature, so it's not a fair comparison. But even then, I would challenge, say, well, you have one factor driving to less immunogenicity, one factor driving to more immunogenicity. I would expect a more balanced view, and this is already hinting that this sub-Q concept may not be as simple as we thought about it. And indeed, if you look at the immunogenicity of different IV and sub-Q monoclonal antibodies that are available in the two formulation, you basically see that the overall rate, and you see the names of these different sub-Q and IV molecules that are available, basically they seem to be having a similar potential for immunogenicity, whether they are given as IV or sub-Q. In the vedolizumab visible study, this was translated anyway, both in the IV and in the sub-Q, to a very low immunogenicity rate of around 6%, as you can see. And we know vedolizumab immunogenic profile as one of these novel antibodies that has been so designed to reduce this potential is indeed quite low, maybe more towards the 12-15%, but still many of those are inconsequential antibodies to the drug. What about the rate of antibodies to infliximab? So again, I showed this in the morning, and just quickly to repeat, basically it was comparable, but if you look at the more important subset in the darker bars of those patients who developed neutralizing antibodies, you see there is a signal for perhaps even a reduction in immunogenicity for the sub-Q infliximab. So this also translates in the newer biologics, which are such as risankizumab, has a very low anti-drug antibody rate of about 10%, but peculiarly enough, with risankizumab, it does not seem to be that anti-drug antibodies affect the concentration of the drugs, and you see those with a comparison between the different profiles of this with or without antibodies in the different dosing of this when it was tested in the psoriasis population. For mirikizumab, peculiarly, it does affect concentration. So this is a little bit a complex figure to decipher. But if you look at the dots, which are becoming more and more orange, these are the ones that has higher rates of antibodies to the drug, ADAs, anti-drug antibodies, and they are more and more found at the bottom part, suggesting a reduced concentration with higher rate of antibodies. So why would that be different between two IL-23 antibodies? It's another question that we will have to learn down the road. But what are the possible mechanisms? Again, we discussed that a little bit in the morning. There is this immunogenicity paradox for sub-Q formulation. One part of it may be this high zone tolerance, where when you instill a lot of antigen to the immune system and sort of shocking it into a tolerogenic state. This is the opposite of what we do when we do a minute desensitization protocol. Part of it may be the immune complex formation when you have a lot of drug in the system towards the target, and with infliximab and TNF, this was very nicely proved in a mice model as well as in vitro studies. So probably it depends on the ratio between the immune complexes and the drug, and when you have a lot of drug concentration, these complexes do not form and do not elicit immunogenicity. And finally, remember the TNF blockade, the anti-TNF itself, is also an anti-immune effector, and it could also in itself dampen the immune response to any antigen, even if the antigen is itself. So another possible mechanism that may be at play. And indeed, this begs the question that we talked about also about whether monotherapy, for instance, for the sub-Q infliximab, where infliximab as a compound, unlike vedolizumab, is something that we often think about giving with immunomodulators. So at least in a post-hoc analysis that has to be taken with a grain of salt as a post-hoc analysis, but in the post-hoc analysis just published, there was not a difference between the combo and mono subgroups of patients in terms of both clinical response, concentration of the drug, but even with biomarkers and mucosal healing. So this could be indeed important for us to remember in terms of immunogenicity and TDM for these moieties. And this comes in line with the data from the SONIC trial suggesting that the concentrations are the main driver of effect. And if you look only at the groups of patients with a higher concentration of infliximab in the blood, those higher concentration groups fare similar whether they are or not an immunomodulator. So it's not so much about two mechanisms of actions working together. It's probably about the reduction of immunogenicity. And if you don't have this immunogenicity to begin with, this is not so much important. So my take-home messages, ladies and gentlemen, I think we are coming to an era where we have to become more and more adapted to this flexible IV to sub-Q. This is why I illustrated, I think, to you that also all the novel biologics are following this assumption, and we didn't have time to talk, but as you know, even with risankizumab now, there is some data suggesting that when you have a loss of response, you can reinduce with an IV induction and return back to sub-Q. So this idea of coming back and forth from IVs to sub-Q, I think, will be even more pronounced in the next future. The switching from an IV to sub-Q formulation of vedolizumab and infliximab it seems to be associated with improved pharmacokinetic for most patient groups, but how this translates to better clinical efficacy, to better pharmacodynamics, is still unclear. Although the TDM rules from the IV world, as I showed you, are not automatically applied, so I think I will have to leave you with more questions and answers, but I love this situation because that means that everyone here in the audience can have a lot of research to do on your next patients. Immunogenicity, however, I think this is pretty much settled, does not seem to be increased with a switch or may even be reduced, so that's something I think that it's pretty much settled and does not require a lot of research. It's mostly about this PK-PD association that we need to learn more. So with that, I would like to thank you for your attention and thank all the people that contributed to this study.